We started? Yeah, 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 yeah.
Yes.
Please first. Yeah.
Yeah. Thank you, sir. So, to speak about the psychodynamic case presentation, this is an initiative by the IPS Faculty Development Subcommittee in association with IPS Psychotherapy Specialty Section, IPS PG Education Subcommittee, the UG Education Subcommittee, and the Indian Teachers of Psychiatry. So, as you realize, a lot of committees which have come together for this special session, which is open to all the psychiatry faculty, UG medical students, and psychiatry postgraduates. And to speak about Dr. V.M. Rajamani, he's presently doing his DM. He's a senior resident at the Center for Addiction Medicine, Department of Psychiatry at National Institute of Mental Health and Neurosciences, NIMHANS, Bangalore. And the chairperson for this session is Professor Dr. Pratap Sharan. And sir is the head of the Department of Psychiatry at All India Institute of Medical Sciences, AIMS, New Delhi. Um, to start with, can I request Pratap Sharan, sir, if you can speak a few words before I ask the other office bearers to speak? Sir, please.
Thank you, Dr. Varun. Would also like to thank Dr. Kishore and the Indian Teachers of Psychiatry for giving me the opportunity to chair this session. Dr. Rajmani's I had the good fortune of chairing the session in which Dr. Rajmani presented in the World Association of Dynamic Psychiatry. It was by far the most comprehensive presentation on a dynamic case in the conference per se, but I think it's in a short span of time he presents a lot of very important concepts, and it was a delight to listen to him. And we look forward to hearing the same. I hope the same case, but at a slower pace, so that we can absorb all the richness of the things that are there in the case. So I would like to welcome Dr. Rajmani to make his presentation.
Thank you, sir.
Thank you, sir. Sir, Rajaman, just a minute before that, I would just request Kishore, sir, who's the chairperson of the IPS Faculty Development Subcommittee, to speak a few words before Dr. Rajaman can start his presentation. Sir, please.
So it's a delight to be part of Indian Psychiatry Society Faculty Development Committee, as also our colleagues in Indian Psychiatry Society Psychotherapy Subspecialty Group also has joined. And then the UG and PG committee, we discussed that there has to be certain cases in psychodynamic approach which are available for the postgraduates and faculty across India. And the Indian Psychiatry Society and Indian Teachers of Psychiatry together have floated many things to enhance the skills of the postgraduates in the psychotherapy. And psychodynamic formulations are very important for our understanding. And I hope these kind of session will enrich our understanding. And Pratap Charan sir, who is the head of the department at AIMS, who himself has a keen interest in the psychotherapy and also psychodynamic approaches. And he presented so lucidly at the Raipur meet when we had. And we also had a fortune of having him as an advisor to the IPS Faculty Development Committee. And we thought that this should be utilized. And when we heard that Rajmani also won the award at the Raipur, we thought that would be a great opportunity to bring him on board and to allow it for larger audiences. And it was delight to know that Varun and Rajmani both were together at CIP Ranchi, and Varun picked up that he will moderate the session because he has interest in psychotherapy. Despite his busy schedule uh, as professor of psychiatry at CIP Ranchi, Dr. Varun Mehta made his time available, and Rajmani also picked up the slot which was there. So I think it's a fantastic combination on behalf of Indian Psychiatry Society and Indian Teachers of Psychiatry. I think this is a fruitful learning, and we would work further to improve these kind of program over a period of time. Thank you, Varun. Thank you, sir. Thank you, Rajmani.
Thank you, sir. Rajamani, can start your presentation.
Yes.
But perhaps I was thinking that we'll sort of do it in two breaks. We'll sort of have a break at the formulation and we'll sort of ask questions and then go ahead after that, if that's all right.
Yes.
Sure. Sure.
Right. I'd start my presentation. Good evening, everyone. I am Dr. I'm a DMC and a resident from the Center for Addiction Medicine here at NIMHANS. At the outset, I'd like to thank the organizers, the subcommittees of IPS, IToP, and my department for their constant support and throughout this process. I'll get straight into the case. It's a 20-year-old. My case is a 20-year-old single male from Bangalore belonging to low socioeconomic status. I failed his 10th standard, currently in a skill building program, enrolled as an electrician. Has a past history of tuberculosis at 10 years of age, a family history of recurrent depressive disorder in the mother, which started postpartum, a completed suicide in aunt 1.5 years ago, a slow to warm up temperament, speech delay in childhood, below average scholastic performance, and an experience of being bullied at school. He presents with complaints of nicotine use since 13 years of age, as cigarettes and cool lip, independence pattern since 15 years with an average of 4 to 5 cigarettes and 2 packs of cool lip per day, cannabis use since 15 years of age as joints, independence pattern since 17 years with an average use of 2 to 3 joints per day, a recreational pattern of alcohol use of around 3 to 6 units a month, and a single time use of 8 tramadol tablets followed by seizure and thereafter abstinence. Over the last 1 year, there's a history of non-pervasive low mood, reduced interaction, irritability, especially towards the mother, following rejection by a girl and physical altercation with batchmates regarding his appearance. And over the last 1 month specifically, following a recent altercation in the family over conducting the second death anniversary of his deceased aunt, there's been a worsening of low mood with reduced energy, staying largely by himself, irritability, making mistakes at his training course, reduced appetite and sleep that were noted by parents and teachers at the course. Over the last 15 days, there's a complaint of abrupt onset of using his left hand to perform all the actions, feeling of left hand not being under his control, repeatedly hitting his left hand against the wall, a transient hearing of anklet sounds at night, keeping blades in his pockets that he doesn't recall how he got there. On examination, it's a thin-built individual with linear scars on the left wrist, shoulder, and foot, an underweight BMI. On behavioral observation, he maintained a downcast gaze, looked constantly at his left hand that was wrapped with threads. There was repeated zoning out during the conversations, occasional tightening and twisting movements of his left hand. I don't know answers to most of the queries. A dysphoric affect. Thought and perceptual abnormalities could not be elicited in much detail. Investigations revealed a B12 and D3 deficiencies. CT and QEG were within normal limits. A provisional diagnosis of dissociative motor disorder, which is functional neurological symptom disorder, dysthymia, major depressive disorder, nicotine and cannabis and dependence pattern, opioids and harmful use pattern, a borderline intellectual functioning or a specific learning disorder, and vitamin B12 and D3 deficiency. So this being the case summary, I now want to go ahead with the psychodynamic formulation of this particular case. So I've used the Richard Summers manner of going about it in a four-part formulation. The summarizing statement being a 20-year-old male from a lower socioeconomic background with long-standing neurodevelopmental and psychosocial vulnerabilities. There's childhood speech delay, post-scholastic functioning, bullying, and a low self-esteem. These seem to shape a very fragile sense of self that is organized around inadequacy, shame, and fear of humiliation. He was more securely attached to his father and aunt, but his relationship with his mother has been conflicted. His aunt, a very important primary attachment figure, died by suicide while he was sitting in an examination. He has never mourned her, and a recent family conflict over whether to even observe her death anniversary has foreclosed any possibility of doing so. Nicotine and cannabis use through adolescence served as possible ways of managing chronic feelings of inferiority, loneliness, and internal tension. The death anniversary conflict recently appears to have precipitated an acute decompensation, marked by dissociative symptoms, altered bodily experiences, largely limited to the left side, with self harm. Together, these reflect a fragmentation of identity and agency acutely that this formulation further seeks to explain. Prior to getting into the dynamic understanding of this particular case, they do not happen in a void. We need to be very importantly mindful of the non dynamic factors at play here. In terms of genetic predisposition, my particular case is extremely predisposed in terms of having a history of maternal postpartum depression. There was RDD and suicide in the aunt. These set up the framework for early relational dynamics and help us understand what could the emotional atmosphere be in such a scenario. Furthermore, his slow to warm up temperament and his neurodevelopmental difficulties, characterized by speech delay, a below average scholastic performance, possible borderline intellectual functioning or learning difficulties, suggests to me that he's someone with a limited capacity for verbal symbolic processing. Furthermore, his experiences of a traumatic nature, bullying during early adolescence, especially around the themes of appearance and perceived inadequacy, lead to chronic humiliation and social fear in the individual. Nicotine and cannabis dependence, the substances, which could be ways of emotional regulation, can by itself lead to dissociative and perceptual disturbances. They are important non dynamic factors at play. Physical factors of a past history of tuberculosis, vitamin B12 deficiency, D3 deficiency, and a previous tramadol induced seizure also possibly suggest that there could be a lower neurological threshold for dissociative states in this particular individual. To proceed with the dynamic understanding of the central conflicts, in my understanding, the central conflict seems to be a longing for closeness and safety on one side, and his deep expectation of abandonment and humiliation on the other. If you look at the early environment was largely inconsistent in terms of the emotional care. A mother who was emotionally unavailable, largely due to her depressive disorder. And furthermore, his temperament with all the psychosocial vulnerabilities and neurodevelopmental vulnerabilities make it harder for him to navigate the emotional world. The aunt was then the major caretaker. He now has to choose between an emotionally unavailable mother, a relatively warm but burdened father, and the aunt who was a major caretaker. He thus unconsciously preserves his father and aunt as very safe, idealized figures, while his relationship with mother becomes or stays guarded and resentful. It is an unconscious splitting. It is a way of maintaining enough internal stability to continue functioning to that tender age. Subsequently, he goes towards, subsequently, there are experiences on the level of, excuse me, bullying. So, bullying confirms his fear that he has been socially unacceptable. The shame and rage that this particular experience generates, one towards the bullies for having bullied him, one towards his parents for having sent him away, and one towards himself for being inadequate, could not be expressed outwardly. Instead, he introjected this humiliating experience inward, and it quietly becomes a part of how he sees himself further going down the lane. Here comes the entry of his early substance use, which seems to be a primary way of managing and regulating his internal distressing states, for which he seemed to not possess any other tools to handle it effectively. Then comes the critical event where the death of his aunt, who was a key caretaker, it was a loss that he could never properly mourn. Furthermore, with his vulnerabilities, his limited capacity for processing grief, combined with a family that doesn't seem to hold space for expressing grief, left his grief with nowhere to go. He did not mourn. Instead, he seemed to freeze the trauma. He employs defenses like isolating the affect that the aunt suicide generates through denial, and he heavily now relies on external regulators, cannabis and nicotine. This is reflected in the history where there's increase towards a dependence pattern at this particular time point. The rage and guilt at the aunt passing away is repressed. He manages to hold on, he manages to stay afloat with this particular defensive architecture. But what happens a year earlier is the two events of romantic rejection and an altercation with his batchmates over appearance. This seemed to again worsen or reactivate his core relational fear. Right? He is unworthy of closeness, and that intimacy, or even attempts at initiating and maintaining intimacy, would result in loss or humiliation. He withdrew further. But finally, when the family conflict happened, the grief and rage that was repressed earlier now becomes unbearable. His existing ego structures collapse. The ego could no longer contain this through withdrawal alone. So what happens is him unconsciously taking on the aspects of the aunt's identity, most notably adopting her left-handedness. The aunt was a left-handed individual, and we find that the patient now has taken it up unconsciously. The dissociations where the left hand acts on its own, the sound of anklets that he hears at night, the actions, all of these actions suggest that these are outside of his conscious awareness or the ownership. The instances where there's repeated hitting of his left hand against the wall, instances of self-harm and carrying blades in his pockets that he has no awareness of, carry the possible symbolic meaning of actually reuniting with her in death. If I could take you through the defensive architecture at play here, from an early childhood foundation, we found that he, in terms of the environment being emotionally inconsistent and an unavailable mother, had to split. He had to hold positive objects in terms of the aunt and the father's uh, helping him in this regard. With such a split worldview, he now has to introject and idealize these aunts as extremely positive figures, the purpose that they were serving very well at that particular time point. Furthermore, going towards adolescence, there is shame and bullying in terms of the experience he had at the boarding school. There is internalization of shame. There is a large amount of withdrawal that you find at this particular time point, and he externalizes or manages these distressing internal sensations or internal uh, distress through substances being cannabis and nicotine. Then comes a critical event of the aunt's death. He never mourned her. How did he help himself? His psyche denies the death of the aunt in the first place. He avoids this particular experiential impact. The isolation of affect probably quarantines him for that particular while. The rage and at the same time guilt that he could not do anything regarding this event to be specific was repressed. This was carried on further till a year before presentation, where the two events of the rejection by the girl and the instance at his training course led to a collapse in that particular defensive architecture. There was withdrawal and there was displacement of aggression, where we find him to be extremely irritable towards the mother and also express wishes to run away from home at that particular time point. Yet, when the culminal event of the acute decompensatory family conflict happened, the rage and guilt that were earlier repressed during the time of the aunt's death and not expressed have resurfaced. Denial is deployed initially. It does not seem to help. Isolation of affect comes to the defense, does not seem to help. Dissociation now comes across as a phenomenon or a defense that helps him stay intact and prevents his psyche from disintegrating. Furthermore, that doesn't seem to help this time around. So now he starts identifying melancholically with the passed away aunt. And given that he has both rage and guilt, there's an ambivalently held love towards the lost object. He cannot be aggressive towards that object. He now turns the aggression towards himself. And how is all of this expressed in an individual with very limited symbolic processing capacity? It is now reflected onto his body. The left hand that he has now adopted unconsciously is now the source of comfort and the source of the internal conflicts. Somatization is how it ends there. So, with all this in context, if I would go ahead with the psychodynamic therapy of this particular patient, I need to be able to predict how the scenario would play out. So, in terms of the resistance and silence, I expect that Mr. B will be highly guarded. His I don't know answers are actually a defensive wall. The zoning out that I found during the conversations are actually his ego shutting down when the content approaches the core conflict. So I decided to respond by slowing, grounding, and restoring safety rather than pursuing the material on an interpretative level. What could be the transference patterns? For someone who's gone through life in terms of how we presented it earlier, he might initially look at me as a judgmental teacher or a bully who's there to evaluate him, who's there to scrutinize him. So therefore, my therapy must focus on ego strengthening and establishing safety as a primary goal. But later through the process, alternatively, he may then develop an intense dependency and he would view me as a protective aunt or a father figure. There could be idealizing transference. Given his vulnerability, the countertransferential patterns in me could be one, the rescue of fantasy, where I would want to save him and rescue him from the ongoing distress. His silence and I don't know responses could actually lead to a lot of boredom and frustration inside me. I would actually be very helpless and dreaded when this particular scenario plays again and again. And at the worst, I might end up over identifying with this particular patient's aggression that he has towards his mother. So I should be mindful of all that in terms of a countertransferential reaction. And as these contexts of dissociation surface during therapy, there's also a very high risk of increased self-harm or increasing substance use as he tries to manage the reemergence of these painful effects. So there's a significant risk of acting out that I must have to watch out for. Overall, how do I see this case in terms of the difficulties he presents and what are things in his favor with which I could proceed with therapy? In terms of difficulties, he seems to be an individual with a limited mentalizing capacity. There's active dissociation and convergence symptoms that are going on a backdrop of borderline intellectual functioning. There's cumulative attachment losses with significant ego weakening, and the family system continues to remain a major stressor. But in his favor, he's a young individual. He has demonstrated real capacity for deep attachment, especially with his aunt. And I see somatic and dissociative symptoms are actually forms of active communication rather than a difficulty. He's tolerated the entire admission process without much difficulty. And he has also continued to be amenable throughout the inpatient care. So these features or these are points that help suggest that I could proceed with dynamic therapy in this particular patient with the following caveats: that the alliance building phase has to be very, very prolonged, that initially supportive and ego strengthening dynamic work or interventions would take precedence rather than outright interpretative work. And my therapeutic frame has to be one where I'm establishing safety and strengthening his affects. I'm reducing self-harm and also helping him identify emotions rather than expressing them through the channel of the body or dissociation. And given his vulnerability to fragmentation and dissociation, my therapy should proceed slowly. I would explore these possession phenomenon and about the aunt through collaborative curiosity. I would explore who she was, what she meant to him, what remains unfinished with her, rather than through direct interpretation of the possession experience. So the goal here is to gradually help him move from being her in terms of how he represents her in his left hand to actually remembering her, thereby facilitating mourning. So if all these go well, we're looking at a therapeutic relationship. If these can survive his idealizations, his silences, his somatic communications, and his grief without actually collapsing, it will then offer him what no other relationship yet has. An experience that has a close relation that as a close relationship this time did not end the way it always has before. And with this backdrop, we would proceed with the management ahead.
So thank you, Dr. Rajmani. And so we have come to, he has completed the first 1/3 of the presentation. We can see that it's not only a case with a lot of rich clinical and dynamic material, but also a case which has been formulated very comprehensively. So if any of the participants has any questions to Dr. Rajmani, it would be welcome. Yeah.
It's one in the chat, sir.
Yeah. So.
Shall I read out, sir?
Yeah, I think Varun, you can read out and Dr. Rajmani could respond.
Yeah, so I am not able to know the name though, but the question is that did the possession only have the left hand aspect, or other aspects of An's personality? That's the question that's been asked.
It's by someone named Iduki. Yeah.
No, it only had the left hand aspect. We did not have other aspects of the An's personality evident in the case.
One more by Dr. Ritika. What other neurological differentials should we think of in the context of young age abrupt onset?
Exactly. So given that that was the initial line of thinking also when we went about the case, that neurologically, the following differentials came to mind. One, there was a very stereotyped nature to which he described hearing anklets and the staring episodes. So we wanted to definitely rule out temporal lobe epilepsy or frontal lobe epilepsies to start off with. Then, at least in the initial half, he had told that one half of his body is where there's a burning sensation equally. The left hand, it's exclusively split up in terms of the complaint. We had hemibody syndromes or hemisensory syndromes as one of the differentials as well. And furthermore, just the left hand probably not being under his control and automatically functioning or carrying out the day-to-day activities. There's a condition called alien hand syndrome also, which we wanted to definitely rule out. Our investigative workup did help us in that regard, and we again were looking at how closely symbolic, looking at how acutely it is linked to the event or the stressful event that has played out. We were confident enough in going ahead with functional etiology than a neurological difference.
Right. Any other questions?
By Dr. Ritika again. So I think Dr. Ritika, you can put your mic on and your video on, and you can of course ask that question. But I'm reading out for you. How can we understand the rescue fantasy countertransference in this case?
The way in which I understood this particularly was again countertransference. What I felt was going to the case history, going to the formulation that I had. What it made me realize is I immediately wanted to have more sessions with the patient. I wanted to have more lengthier sessions with the patient. I was very much willing to stand through his silences, even though it was not leading to a lot of meaningful work in that sense. So I thought that is how it played out in me, where I wanted to be there for him at any cost. So that's how I understood the rescue fantasy countertransfer in this particular case.
Okay, any other questions? Right. So I think Dr. Rajman, you can proceed with the second
Yes.
third of the presentation.
Yes. Yes. Going ahead as part of the management plan.
Full screen, please, I think, yeah.
So given the scenario, an inpatient admission was considered. All the safety protocols in the ward were upheld. Sertraline 50 milligram was initiated and was titrated up to 100 milligram. B12 and D3 supplementation was given. There was a structured routine that was imposed in the ward, and a therapeutic contract was taken in this regard from the patient. I'd like to discuss the management under probably four a very arbitrary hypothetical phases that I believe I went about. In phase one, where my primary goal was to become a non-threatening presence, where containment, safety, and the first object representation was important to me. To become a non-threatening presence was my primary task. The emotional atmosphere during these sessions was largely silent and still. So I held deliberate restraint. There was no note taking, there was no interrogation, there was no active pursuit of material from my end. And largely, there was an intentional quality of patience and acceptance from my end. But yet, at the end of most of these silent sessions, if I could put it that way, I left feeling that something had happened, despite almost no verbal exchange in this particular phase. The main themes were his extreme guardedness and the use of silence. His active I don't know answers were a defensive wall, and it seemed like a protective strategy. His first spontaneous disclosure that he was not sleeping well over the last few days and hearing anklet sounds at night was offered very obliquely. And the beginning of micro engagement began by around session 3, where there was brief eye contact compared to the previous sessions, and he was giving more than one word answers by around session 5. Throughout this phase, the therapeutic interventions from my end were to deliberately leave out notes outside the room, where I was signaling to him that presence meant more than performance or procedure in this regard. I used silence actively, I did not fill it, and I treated it as a possible legitimate therapeutic space that we were in. I only made brief, non interrogative observations, like it's very hot today outside, the ward is actually loud this particular day. And I received his I don't know answers without any challenge or pursuit. And all through the while, I was tracking his dissociative indicators in terms of finger movements, the quality of gaze that he was in, giving me, the zoning out during the conversations all throughout. In phase two, where I wanted to know or map his inner world and I wanted to see it emerge, the primary task was to understand the map of his inner world and all the people that mattered. Here, in terms of the emotional atmosphere, a shift actually occurred at around session 8. When he initiated, you keep taking my updates from the nursing staff and ask me about whether I've eaten or slept well. Why do you keep coming back? So, this marked a move from passive tolerance throughout the process to actually tentative trust in me. The sessions further became relatively warmer, but still were pretty guarded and careful. There was stillness around certain topics, particularly the topic around the aunt, that I tracked as a signal of charged material that was soon coming to approach. By session 10 was when the loss was first named, and in session 14, the left hand connection first surfaced. The main themes were the aunt as a primary attachment figure. He mentioned that she used to keep extra foods specifically for me. The naming of her loss. He mentioned she's gone, and he said this without full dissociation, which in itself was a very clinically significant landmark. The left hand was represented as a somatic memory by around session 14. He mentioned she was left handed and used to feed me with that hand. She held me with that hand. The first moment when the symptom and the object relation actually touched each other. And the patient's own emerging insight when he asked, do you think she's in it somehow? And it sounds like the hand is still being held, and these were arrived at independently by the patient. The interventions from my end during this period were to build a detailed picture of the aunt as a person, who she was, what she meant to him, what she specifically provided. And this served dual purposes. One, about gathering information, and also giving him the experience of speaking about her to someone who received her with care. Then I gently observed that the hand moved much more when they talked about her. These were the first preparatory linking between these two symptoms. And when the patient asked if she was in the hand, I received it with complete seriousness and just reflected it back. It sounds like the hand is holding on to her, and did not have any interpretative work at this time point, thereby allowing the patient to arrive at his own insight. In phase 3, my primary task was to accompany him towards what cannot be said yet in terms of the grief, in terms of the guilt, and the death. The emotional atmosphere this particular phase felt to me as the most charged phase of the treatment therapy sessions. He actually began arriving with things actively on his mind and asked more questions. It was a qualitative shift, at least, from how passive the previous sessions were to how actively we were using the therapeutic space. In one of the sessions where the death was disclosed, it was very heavy and still. The guilt when it was surfacing that he could not do anything at that time point, we were very slow and careful. And again, went back to session 1 where we were pausing and silent for a major part of the session. The session that discussed rage was again one of the most active the therapy had yet been. My role throughout was to hold the charge without actually fleeing or rushing or reacting to it. The main themes were one, the anniversary conflict, that the family had cancelled the death anniversary, which was the precipitating event. He disclosed that the only time we talk about her was then. And this seemed to be the psychodynamic key to the presentation. The manner of death. He used the word suicide that was spoken out for the first time in any space. After session-long approach through multiple peripheral ways in which we tried to understand what happened to the aunt. The guilt that if I had gone to see her that week, he was actually writing an examination at that time point, and the guilt that if I had gone to see her that week, and the irrational conviction that probably his presence might have actually saved her or not led her to a suicide. Then the rage at this particular lost object that she just left, she went, she didn't give me a chance. So this seemed to be one of the most well guarded and defended affect in the entire case. It was protected by idolization. We work through the ambivalence, the love and rage, and the guilt that he has rage about that particular lost object were held simultaneously. The interventions from me at this end were one, to receive the disclosure of the manner of death with thank you for telling me that. When the guilt actually emerged, I asked him, how would you know? How would a person actually know someone that they love is in that kind of pain if they aren't actually showing it with an attempt to probably reduce the guilt that he holds that he wasn't there at that time point? We worked again repeatedly through the same territory of rage, guilt, and idealization in many ways, with each time the conversation adding more layers and depth. I held the aunt's complexity alongside her warmth. So I neither defended nor diminished the idealized versions that he mentioned about the aunt. And the attempt was to allow her to seem as human and as probably humanly flawed that can exist rather than her remaining a very idealized object in that sense. And in this phase, the capacity to hold ambivalence without splitting seemed to be a prerequisite for genuine mourning, that you cannot actually mourn an idealized object. Proceeding to phase 4, where we were working through and consolidating the events we had earlier. The primary task was to build a self that can carry this particular loss forward. In terms of the emotional atmosphere, this was notably different from the preceding phases. It was much less charged. He arrived again consistently. He brought active material to discuss, and there was an applied understanding rather than a need to be accompanied towards it. And increasingly, there was a quality of self recognition. He could notice the left hand now, and again, objectively, as an external observer, say, there it goes again, with a mild distance rather than actually being alarmed by it. And this was a time when he had actually gone back to a skill building course, and there was actually a small and real moment of competence and self observation at that skill building course. The main themes again here were symptom resolution. There was a shift in terms of substance use where he had reduced cannabis and nicotine during that time. He mentioned the mother here that it was raised by me to speak about the mother and not the patient. And he mentioned she's always been far away even when she's in the room. Earlier, whenever the mother stayed around or came to the session room, so he actually went silent even after a period where he was actively sharing material. Again, staying in the room at the course, there was actually an error he made when he wrongly connected a few wires at the course. And for the first time, previously, probably his reactions were extreme internalization and feeling shamed and humiliated. But the first time he named it as a feeling, that it was an odd feeling, he contextualized it, he stayed with it rather than fleeing and internalizing it fully. So this particular consolidation phase of central achievement is what I think this moment displayed. The interventions during this time were one, we allowed the substance use reduction to actually emerge as a consequence of internal development. It was not a major therapeutic target through most of the sessions. The mother's topic was raised actively, understood that it could not be left unaddressed if consolidation is to be fully, thoroughly done. The same whole object approach that we adopted with the aunt was again used with the mother, that where we neither blamed her nor excused her, but understood where the patient actually came from in his understanding of the mother. And I also started thinking about termination, as it was a very essential task that had to be accomplished. The comments to this session were that the cannabis reduction was actually a marker of genuine internal structural change. And I felt that the person was now having an observing ego, a third person observer ego, that was relatively strong enough to step aside, look at the particular shame activating event in real time, name the exact emotion that he felt at that particular time point, understood it that he did not have to flee from there, and made a different choice. He did not eliminate the feeling, he named it, contextualized it, and stayed. Termination is a very important segment in this particular session. The focus was on having a very planned, collaborative, ritualized ending, which itself could be a therapeutic intervention for a patient whose entire history was defined by losses. And these were losses that arrived without preparation and without adequate containment. The emotional atmosphere again was much quieter. It was more reflective than all the preceding phases. He responded to the word ending with tension, and it eased when we actually framed the ending or the termination as a proper ending where we planned it together. The final session was again sad, but was settled simultaneously. The interventions were we gave adequate lead time. We took up around 7 sessions to actually terminate this and ensured that the ending was not just another sudden loss. We framed this entire termination as a collaborative marked event, whereby a proper ending was done together. In the final sessions, when I asked explicitly, what do you remember of the beginning? What are you taking away now? I wanted to structure a backward and forward look as to how far he's come. And the threads that he was initially wrapping around his left arm before he went about hitting the wall had actually given it. So I received the thread without further elaboration, simply accepted it as a containing gesture, and I said I'll keep it. Again, I communicated explicitly in the final session that in case you manage to return to therapy, if there's a failure, it would not be deemed a failure and you can anytime walk in for therapy. My comments to this particular phase was that termination was itself seemingly a corrective emotional experience. Every loss in his life had arrived without warning or without any adequate mourning that followed the loss. This ending was, however, different. It was named in advance. We prepared for it collaboratively, we planned for it, and then it was marked at the close. To assess how far the progress was there, a mention of certain aspects here. In terms of symptomatic change, the dissociative symptoms that he had initially come with, we had a near complete symptomatic resolution of this acute dissociative episode. There was significant and durable improvement in the mood and self-harm. However, dysthymic vulnerability seemed to persist. Substance use, there was significant reduction in cannabis use, consistent with our initial psychodynamic predictions. Nicotine dependence again requires continued specialized input because that was something that he continued to use. In terms of structural change, what happened to his ego functioning and defensive organization? There seemed to be a significant shift in his defensive organization from a very pre-verbal, a very primitive or somatic way in which his defenses operated towards a more flexible repertoire where we have an observable, decent enough observable meaning, observing ego capacity. And there seemed to be a meaningful and durably improved capacity for mentalization as well. He could now identify and name a range of internal states, the emotional states of sadness, anger, scared, relieved, the odd feeling, the examination feeling. Now he can then connect these internal states to actual precipitating experiences in real time. In terms of the internal object that changed, in terms of the relational dynamics, the ant was now a whole, real, specific, mourned, and a complexly held person who was present in memory as a mental representation rather than being enacted in the body as a possession. The mother, again, the relationship still stayed genuinely complex, and I think that's a work in progress. In terms of the therapeutic relationship in the final session, he named the quality of this relationship as something that's consistently available, was non-humiliating, non-abandoning, and that this object, that is me, did not disappear at termination. In terms of functional change in daily life, there's no consistent attendance at a skill building program. He's now able to remain in the room when shame or events triggering that is activated at the course rather than fleeing away from it. He's now beginning to have better engagement with his batchmates. He's now able to name his own emotional states to himself in real time. However, I think nicotine dependence for which replacement therapy was started and dysthymia for which Sertraline 100 mg continued, these would be conditions that would be monitored alongside the work that I believe with the mother has to be done more diligently. Yeah, so thank you.
Okay, so thank you, Dr. Rajmani, for the presentation. And I think there are a couple of questions in the chat. So, one of them relates to the formulation itself, and the other one was more for the second half of the presentation. So, Dr. Varun Mehta, would you want to take up the
Sure, sir. Sure, sir. So that's for Dr. Nitisha regarding formulation. So she asked that we frame a formulation according to our understanding, but suppose the patient doesn't communicate adequately, dissociates frequently, no progress. How to move further is what she asks.
I think again, I mean, in my understanding, the formulation is not a very fixed or a static entity. It can be dynamic. It should be flexible, taking into account how the particular the sessions are playing out, and I think there is scope within the formulation to be as flexible and has a scope for change over there. If the patient doesn't communicate adequately, dissociates frequently, and there's no progress, how do we move further? Further, again, in my limited understanding, I think the initial supportive framework that we adopted psychodynamically, I think that will take a longer course. We should be pretty mindful of the countertransferential reactions that these phenomena can actually elicit in us. And I believe it is actually running a more longer course than any other alternative routes that I would take. I would still stick to my ways in which I wanted to have strengthening or supportive frameworks of psychodynamic work, and that is how I would approach and move forward further.
Right. The other is by Dr. Trishita. So she asked, in a similar vein, so if a patient is guarded and not communicating adequately, would it be appropriate to use some leading questions?
Certainly, again, so I think the timing and when would you want to start out with asking leading questions again becomes important as much as what the leading questions directly are about. So here, if the leading question is again about directly addressing the hand, what's happening to the hand, what happened to the ant, I think before adequate uh, alliance in terms of relational presence is built up, uh, I would not prefer going across with leading questions until I'm very, very comfortable with that in the first place. Again, I would interpret this silence as therapeutic. I would again want to understand what exactly the silence means. I would still look at it as a defensive strategy that the particular patient is employing, and I would be skeptical of when I would start asking leading questions.
So, I mean, in a sense, I think what she's trying to understand is would it be appropriate to use some leading questions? So, do you realize you say that you would be skeptical in the beginning to use the leading questions? There's the other question by ASM. I don't know if it's a him or a her, but the question is that there was a mention of borderline intellectual functioning. Did it have implications during the interview sessions? The patient having difficulty to understand and articulate thoughts, for instance.
Yeah, so I had the mention of borderline intellectual functioning. In terms of the implications during the interview, again, no, because the patient otherwise was very, very adaptive in terms of his, I mean, he was functional in terms of his adaptive capabilities and capacities. I did not find that to be an area that was interfering during the sessions.
Okay. Any other questions that people may have? Or now we can move into the third phase, I suppose, which is about discussing the case. So if people have comments on the case, if they would have kind of done things differently or they agree with the way the therapy has moved. Maybe I can get the discussion started by kind of considering a few things. One is that this was an attempt at focused kind of psychotherapy in the sense that it's dynamic in its approach, but you seem to have picked on certain things that needed to be handled in the sense that you were focused that the dissociation particularly was taken care of and he's able to run through the grief for his aunt. That was the primary goal of treatment, that one takes care of dynamics around grief and dissociation. Uh, uh, you uh, the, don't seem to be addressing the basic personality structure of the person, which makes sense considering that this is the most distressing thing, and the personality, uh, the functioning of the person is somewhat uh, the borderline, but it is not dysfunctional completely. He manages, he was training and he was able to run his life at least at a uh, within the kind of normative range of functioning possibilities. I think that should be kind of recognized that it was an attempt at focused treatment. This is a hallmark of usually brief therapies. Brief in psychodynamic terms usually means between 20 to 50 sessions. So that seems to be the approach in general. Uh, I would like to have your comments as well as Varun's comment on this, and if anyone else wants to discuss something around how psychodynamic psychotherapies are structured in terms of time flows. Rajman, would you want to comment yourself?
Yes, I mean, that is exactly the approach that was taken because the major reasons for presentation, the major concerns at that time point throughout the IP care were these particular things. So I found it fitting that these would be taken care. And more so, I felt that to work on the level of personality, he is someone that I wish to continue to take sessions and continue to keep him under care. But then these problems seem to be the emergent conditions, and that is why the focus was much specific and narrow. And furthermore, I felt that even if I could look at what uh, frameworks of psychodynamic would apply here, it was pretty pluralistic in the sense that there were there were aspects of object relations, there were aspects of self psychology, there's aspects of ego psychology. Fairbairn had mentioned to a certain extent. So I felt if I open up or explore it in more detail, I would again be confused with the number of pluralistic directions it can take. So the current presentation and the current manner in which I went about was specifically targeting those symptoms.
Right. So the other issue that Dr. Rajmani has brought out is that there are different schools within psychoanalysis. At least three major ones. One is object relations, the other is ego psychology, and the third one is self psychology. And usually, when one does treatments, one follows one of these models predominantly, even though techniques from the others are naturally they get incorporated, but one tends to use one of them more prominently than the others. Any comments from the participants regarding this? Okay, so okay, a third point that I would want you to respond to is that when one does the dynamic work, particularly from the object relations perspective, typically objects, I'm talking about long-term dynamic work, not the focused dynamic work that was attempted here. The objects that one is talking about are usually not people per se. It's not that the mother is the object and the aunt is the object and the father is an object kind of a thing. The objects that we are talking about in the internal world are they are if I use Fabianian terms, then it will be something like an exciting object or a rejecting object. And usually the exciting object or the rejecting object is an amalgam of all the people out there. All the people means all the important people out there. So like the exciting object will have elements of the aunt, and the father, and maybe sometimes even of the mother. The mother might have been exciting at times and rejecting at other times, kind of. So uh, typically the formulation in those concepts are done in terms of these internalized images, like rather than the external objects. But I think your goal here was a little different in the sense that you're trying to help him mourn an external object who is lost. So your comments on that.
Yes, sir. Sir, again, in response to the query, the way I understood that was one, the presenting complaint was very closely symbolic to a figure like the aunt who was again actually left-handed. I think the complaint itself was very, very symbolic that she is the primary central figure that I would probably want to help the patient mourn or facilitate mourning with. So in that regard, I did not probably go deeper into understanding how a particular object can still be an amalgamation of multiple other things. So, and I believe certainly that would have been the case as well if we continued with more longer sessions. Because rightly said, a particular representation or internal objects are amalgamations of multiple versions of each. So the mother could have been exciting at times. She definitely was rejecting for a major portion of it. The aunt, again, in that regard, was mostly exciting or a primary attachment figure than very little rejecting scope over there. So just because the symbolism was too very specific and was very direct in terms of work, I right away went out with such an approach.
Again, I'll open it for other people to. These were some of the initial kind of discussion points, but if other people want to, in dynamics, people should be ready to speak. Otherwise, we are facing the kind of thing that Nitisha had raised, that if you're all dissociated, then how do we make further progress? So, Dr. Ritika, Dr. Rajesh, there are 20 odd participants. If anyone wants to speak, should learn to hear your voice so that you become more comfortable with talking to people.
Hey, Raju,
Okay, so
let me just try. So that's all right. So, I mean, in terms of the dysthymia, do you think you've been able to conceptualize the dysthymia as well? So, the conceptualization sort of revolves around the dissociation around it. There's an understanding that dissociation could also be a larger symptom complex under the domain of dysthymia or even maybe a depression. Is there any way to work out? You sort of terminated the session. Do you think the scope for continuation of the sessions provided that a certain aspect is still there, say in terms of the dysthymia as well?
Yes, sir. So the way in which I conceptualized it, but then I did not have a therapeutic outlet for that was one. I think this current acute decompensation was, I mean, the dysthymia probably was a result of a defensive architecture that he had adopted soon after the aunt's death. And that somehow helped him for a while till this particular recent 1 month decompensation. So the depressive episode, I look at it as a collapse of that particular defensive architecture alone, where the ego subsequently has eroded over a year. I did not manage to conceptualize it separately because I expected that given this particular decompensatory event, as part of therapeutic work, we would again work on the event that led to it, which is the mourning of the aunt. So I expected dysthymia also to probably come down as a consequence of this particular session itself. I did not have a separate formulation or a strategy for that.
I think what the Dr. Rajmani is kind of trying to communicate there is that when we do a dynamic formulation and dynamic therapy, we are not focused on one all the different psychiatric manifestations per se. Like when we talk of central conflict, suppose we are looking at the dissociative issues as the central issue there. We may not try to. In a human being, it's not possible to resolve everything that they're dynamically capable of. Everyone uses all 50 different defense mechanisms at various times. Everyone will go through some amount of depressive psychopathology at all times. So when one does the dynamic work, when the dynamic formulation, one is looking for the central themes and one is trying to take care of the central problems. And one expects that as the central things get resolved, the person learns how to identify their own dynamics and they learn to resolve the other things by themselves. So I suppose this is similar to all kind of treatments that if in psychopharmacology also if we have a depressive thing, we sometimes only take care of the serotonergic part and we expect that the rest of the problems will kind of handle themselves out. Or if you're doing cognitive work, then we're looking for certain kind of problems, and after 20 sessions one expects that the person has learned how to handle things further. So there is a new question there in the box, but I think we will not take questions from the box anymore. The person who puts the question has to speak it out now directly. And this
Pratiksha, please,
Yeah.
be great if you could.
Hi everyone. First of all, thank you for the case presentation. These are not common to access, so thank you for that. I had a question, especially in the Indian context. Family factors become crucial in carrying out therapy or ensuring adherence to treatment. So, in dynamic therapy, do we include that, or is that not appropriate to address? I was curious as to whether we approach family members uh, when we uh, carry out the work with the individual.
Again, yes, certainly. If I could take a cue from the lecture we had, I think 2, 3 days ago on psychodynamics in child and adolescents psychiatry, sir had mentioned about a concept of homeostatic resistance, and then we had a discussion of how parents probably for their own unconscious needs, can either promote further therapy sessions or sometimes even take a child out of therapy much earlier as soon as the autonomy or improvement is seen. So certainly these factors would certainly come into play, and probably anticipating them beforehand would be a good practice that I would suggest. Here again, as a matter of chance, the mother, who was pretty much the rejecting figure, so after the initial 2 or 3 days of his IP care, she had to leave back to work, and the father was the consistent caregiver throughout the period of admission. I certainly believe that your family does have their own positive and negative aspects to contribute to the case, and we should also look at the unconscious patterns going on in that regard as to how it actually impacts the ongoing work of patient.
So they are also included in sessions intermittently.
No, they are not included in the sessions. It was here primarily on with the patient alone. The sessions were largely in a private space with the patient alone,
So,
or at least academic work was not done with them in that regard.
so normally it's believed that when you're doing brief therapies or focus therapies, if there is negative transference or negative counter transference, one kind of interprets that. One doesn't interpret the positive things, basically because if the treatment is progressing at fairly, then one doesn't need to interpret positive transference and counter transference if you're doing a brief therapy. In a similar way, if the family is not likely to be a resistance to the treatment, you will probably not intervene with them. You might want to intervene with them if they are likely to create problems, in which case you may take sessions outside of the therapy session. You will have to talk to them, probably explain certain things, but usually it's not a good idea to have a family member sit in a session because that disrupts the internal dynamics.
Thank you.
Hello, can I say something?
Yeah.
Yeah, it was a very nice presentation. I was just intrigued that it was a long session over many phases. And things which we are not particularly used to doing. So I was wondering how the therapist was on his own interpreting and analyzing, bringing in the concepts, or did the therapist had somebody who was also consulted and in a guiding role? So I'm just interested in knowing that. Thank you.
Thank you, sir. Yes, I was supervised through the sessions. I had a supervisor.
I suppose the case was from NIMHANS, and NIMHANS has a setup in which therapies are. There is a set of supervisors, and many of the courses, therapy is a part of their training program itself. Anyone else might want to?
Hello, good evening. I'm Dr. Aniket. I'm a third year junior resident. I had a few doubts. One is like since it was as the sir mentioned, it was a brief intervention kind of a picture. So I wanted to ask why. Since psychodynamic therapy takes a longer time, and also given the patient's level of functioning and everything, it would have more sessions would have made sense. So why? What was the like? Why was psychodynamic therapy chosen? Is my first question, and secondly, I would also like to ask one another doubt is, since patient it looks like patient might have a complicated grief kind of a picture as well, given the aunt's death, and is not able to mourn the death. So guided mourning could have also been like a one another option which could have helped the patient, is what I felt during the presentation. So do you plan is that a part of the plan in the further sessions, or is what I would like to ask? Thank you.
Yeah, to answer your second question first, again, that will not be part of the plan because I think we've achieved the targets in terms of facilitating morning for him. So there's no pertinent need to add in guided morning as an interventional strategy. Again, for the first question, again, a very pertinent one as to why I chose psychodynamic psychotherapy again for this case. Well, very simply, we could have had biological ways of stabilizing him pre the depressive episode and the other comorbidities that were noted. But then, analyzing the history, I did feel that, I mean, most of his defensive architectures have been pretty maladaptive right from an earlier phase. To the vulnerabilities that I mentioned in terms of neurodevelopmental and psychosocial. So he would be someone with very limited verbal symbolic processing. Three, again, this particular event, which was precipitated, had a very strong symbolic representation and it opened up attachment failures, right? That is, I mean, to an earlier time frame that is rooted way ahead in childhood. So I thought uh, this would be one area that I would explore where just beyond superficial biological stabilization and management, we could have more larger ego restructuring benefits if we take up something like a psychodynamic framework.
Right. I think the question is very similar to why will you give, let's say, escitalopram rather than desvenlafaxine in a given patient, or basically of what happens usually is that if you have various therapies which are equally effective, you choose the one that you're familiar with. Like all of us may note about 30 antidepressants, but most of us use about 4 or 5 typically. So that is based on what you're comfortable with. And if you're equally effective, then it doesn't really matter whether you're using this or that, at least in the beginning. And increasingly, we are finding that there is a decent amount of efficacy data coming up for psychodynamic psychiatry. Like 20 years ago, it appeared as though CBT was the only way of doing the treatments. Now there is more data, and various other forms of psychotherapy seem to be equally efficacious, particularly when you're dealing with common mental problems. There seem to be a certain amount of efficacy. If you are dealing with personality problems particularly, then it seems that there is more evidence available for psychodynamic work, which doesn't mean that it is more effective, it's just that there is more evidence available then. The kind of therapy that Dr. Rajamani has done, I think he has taken close to probably 20 to 30 sessions. And that is very similar to what you would do with CBT. So it's not as though this was more time intensive than any other form of psychotherapy. So even though on the whole psychodynamic work usually takes more sessions and is longer, but often you are addressing things beyond just symptoms, or like it's not only about taking care of depression or dissociation. You often move into personality structure of the person. So the reason why it's longer is because it is addressing another set of problems. So I think one point that I would want to make for all of you is that if you are looking for brief dynamic psychotherapy, it's like doing T20 of cricket. Look, it's not necessarily very long. Like a football match takes 3 hours, and IPL T20 takes 3.5 hours. So these are not like a football match takes about 2 hours, let's say. So these are not extraordinarily different from each other if you're looking at focused kind of issues.
Okay, thank you, sir. That answers my question. I wanted to ask one another thing is, like, if I may, I like since a patient is predisposed to like the illness, and like there are quite a lot of predisposing factors, is what I mean. Is there some like are there any measures that we would want to take at this point, like in the future follow-up sessions, where we build up his resilience, or like so that he doesn't have a decompensation in future again at in such a manner, is what I want to ask. Thank you.
Right again. So in the slides where I mentioned about the course and progress, I think I've split it across domains where one major aspect was about how the internal structure was also changed in terms of the defenses that he's currently using. So from a psychodynamic way, if I want to build up the case or an argument for the fact that we've already helped mitigate some of the factors that could lead to a relapse, I think that was evidence in that sense, where we found the major ways in which he now uses his defensive architecture, the ways in which he reacts to shame or triggering events at his workplace, the ways in which he understands, how he looks at errors as something that he should verbalize and take a third person perspective of it. I think these were all factors that would make me at least convinced that he is decently well positioned to not have a relapse in the near time future. But then that's again, it's probably because I did the thing and it's something too personal and close to me. I think the answer comes equally from that stance as well. So I'd want my teachers to again give me a holistic answer.
I can say that's
I
a
would look
safe
at
answer that you're saying.
I would look at it in a simple way that suppose a person has tuberculosis and there is a lot of social disadvantage around him. So after you give him a treatment for tuberculosis, you may feel that he is settled and you may not do anything more. It's not necessary that the person who's treating will take care of the social deprivation around. On the other hand, if you feel that there are certain things which are very specifically problematic, that he is living with 4 other members in a family who have tuberculosis, then maybe you will do some kind of work to take care of that. So the decision as to whether you will continue to build on the person's requirements will be based on how imminent decompensation you are expecting. So in this case, Dr. Rajmani probably expects that there will be no imminent decompensation, so he could terminate treatment. But at the same time, he has left it open that if the patient wants to come back and work with other aspects of his self, then the treatment can again be restarted or it can be reformulated in a different kind of a structure.
Okay, thank you, sir.
So I think we have had a pretty interesting case presentation and also some very important issues of how to choose and how to manage families and other issues which are very practical kind of things in our setup. These were raised and discussed. As a first kind of student presentation of psychodynamic case, I think it is very important that we have started talking about psychodynamics now. We have started using some of these terms. We are able to connect certain activities that are occurring in the therapy with the movement that are occurring inside the person's inner world. I would expect as we go forward that more internal discussions occur. Like today's discussion was more about how to deal with the family, for example. That to me, from a dynamic perspective, is the external discussion. Whether we choose one form of therapy or the other is, to me, external discussion. To some extent, it was, and this is true of Indian psychiatry in general, that we are wary of dynamics. It's almost as though we feel that this is something which is a cauldron and we will not really know what is happening inside. But there is a lot of hesitation of going into dynamics. I think as we go forward, our hesitations will come down and we will start talking dynamics in a more natural way in that sense. And I would like to congratulate Dr. Rajmani for doing an excellent job of approaching the cauldron inside. One thing which I would want if there are further, not if, but when there are further presentations, is a little bit of the case material itself could be kind of brought out in the sense that you actually made this presentation for a very brief presentation to begin with. So the statements of what the patient spoke and the statements that the therapist made, that kind of like a little bit of the real session might be a good addition to the further presentations in that sense. But on the whole, I think Dr. Rajmani, you've done a wonderful job. Thank you.
Thank you.
Thank you, sir. There's always a lot to learn from you, as always. And what we'll do is we'll ensure that the next speaker actually has the session notes as well during the presentation. What we were actually a bit not certain as to how to club everything in an hour. So I think that was a challenge which we were facing, but we will surely try. So thank you, sir, once again. Thank you, everyone. Thank you, Kishore, sir. We'll close the session, and I hope that we'll meet everyone again for the next psychodynamic case presentation. Thank you.
Thank you.
Thank you.